Hello, everyone. I'm Fatima Hidayat, and my colleague Saloon is here as well, and we're fifth-year medical students. Welcome to the third session of our A2E assessment. So today we're going to go through two scenarios. The first scenario, I'm just moving on to the next slide. Yes, so the first scenario, you are the junior doctor on a medical ward. The nurse calls you to see a 41-year-old woman who is now drowsy and not communicating. Please perform an A2E assessment. You may ask the examiner about the patient's physiological observations and information as you go through the assessment. So first things first, you go inside the station confidently and you introduce yourself to the person who's handing over to you. They might give you a very brief history. So our patient is called Jane. She had an operation a few hours ago and she was doing well. But recently she became drowsy and she stopped responding. So you approach her and you introduce yourself. However, she does not respond. What do you do next? So you want to assess the airway. You've identified something. She's not responding. Take a few seconds to think what the next step is. And feel free to drop your answer into the chat box or just unmute yourself and share your thoughts. Okay, so the patient is not responding. This means that you can't know if their airway is patent or not. So someone suggested head tilt, which is a maneuver that's excellent. But before that, you would want to see if there is any airflow. So you can either do that by taking your ear closer to the patient's mouth or nose to see if you can feel their airflow, or just use your hand to take it closer to their mouth and nose and feel the airflow using your hand. Next, you would want to ask the examiner if you can hear stridor or wheeze, or to check if they have any central cyanosis. So once you've made sure that there is no visible obstruction in the airway, you immediately call for help and perform maneuvers. This is a maneuver. As you can see, we do this maneuver to prevent the tongue from obstructing the epiglottis. So head tilt, chin lift. That's correct. And then for our patient, they responded to this maneuver, so we can now safely move to breathing. However, I just want you to think about a case where the patient does not respond to the airway maneuvers. What would the next step be? Okay, so I can see some answers here. So if the airway maneuvers did not help, you would want to use some devices to help you maintain the patient's airway. So an example of a device can be the Guedel airway or the oropharyngeal airway. In our previous sessions, my colleague explained how to measure the size of the Guedel airway to see if the size is appropriate for the patient or not. Can someone remember how to measure the size of a Guedel airway? Okay, so I can see some answers here. So we measure it this way, from the midpoint of the incisors to the angle of the mandible. And if it was the appropriate measurement, then we use it. But our patient did not need this airway device. Their airway was patent with just the maneuver. Next, we move on to breathing. So we check their respiratory rate. Next, we check the depth and effort of breathing. How do we assess that? We can do that by asking the examiner if the patient is using any of their accessory muscles. We can check these if the chest has symmetrical chest expansion. So by putting our hands around the patient's chest and asking them to take a deep breath in and out to see if the chest is raising symmetrically or not. Once we've done that, we can use our fingers to see if there is displacement of the trachea, if the trachea is deviated to one side. And next, we can percuss and auscultate. So in our percussion, we need to look out for things like hyperresonance, or in our auscultation, if there is any dullness at all. Next, we would use the oximeter to check for oxygen saturations. So for our patient, the respiratory rate is 10 breaths per minute, and saturations are 90% on air, and the chest is clear. So can you just think of what you need to do now? You've assessed breathing, you've identified a few abnormalities, now we need to treat them. So could you suggest a few investigations or managements that you would want to do before moving on to C? So someone suggested chest X-ray. That's a very valid and sensible investigation. Non-rebreathe mask. All right, so what you would want to do is to perform an arterial blood gas and then give them oxygen as soon as possible because their oxygen saturations are very low. So you would give them 15 liters of oxygen via non-rebreathe mask, and then you would also order a portable chest X-ray. So once you've done that, you can now safely move to the next step. With circulation, you're trying to see if your patient is well perfused. So you do that by checking the blood pressure, heart rate, capillary refill time, temperature, and if the patient was catheterized, you would also want to check their urine output. So you've assessed these things for our patient, and you found out that these are her observations. So what are you thinking now? What are the abnormalities here, and how would you treat them? Exactly. Someone said the blood pressure is low, so we need to give fluids. That's correct. So we put in a large bore cannula, and before putting fluids in, make sure you take your bloods. So just the bloods that you would always routinely take, full blood count, urea and electrolytes, is useful in this case because the patient is post-op to get a clotting screen, and group and save in case they needed a transfusion later. Now, ideally, with all unwell patients, you would want to check lactate. But because in the previous step, I've already requested an arterial blood gas that will have lactate in it. If in your breathing section you did not request an arterial blood gas, then at this point in the circulation, you can order a venous blood gas. Once you've taken the bloods from the cannula, you can give an IV bolus of 500 milliliters, 0.9 sodium chloride over 10 to 15 minutes. Now, is there anything else that you would like to do? Again, you won't be marked down if you don't do this, but it's also useful to let your examiner know that you're thinking of starting a sepsis protocol. So give 3 and take 3. Since you're already doing it, it would be useful to just say that you might as well do blood cultures in case the reason for why the patient is feeling this way is sepsis. So at this point, after assessing circulation, you can either reassess airway breathing circulation before moving on to disability, or you can move on to disability and then exposure and then come back to A and E. But either way, reassess. So what I do in an exam situation, just because I don't want to forget all the management, and it also gives me some time to think and revise what I've done, I would normally stop at this stage and reassess A, B, C before moving on to D and E. But it's up to you. Again, do what you're comfortable with, but make sure that you reassess either way. So In disability, you would want to check the neurological status. So the gold standard for adults is the GCS. However, again, in an OSCE, you wouldn't be marked down if you use the AFPU. So our patient was alert. Then you would want to check pupils using a pen torch and blood glucose levels and pain. So just like we mentioned in our previous A2E session, I use the mnemonic GAP to make sure that I don't miss anything in disability. So G for glucose, A for AFPU, and double P for pupils and pain. So our patient has a blood glucose level of 4.6. She is alert on AFPU. She has pinpoint pupils and she is responsive to pain. Now, at this point, can you please share what your top differential diagnosis is? Okay, so someone said opioid overdose, and that's excellent. Because pinpoint pupils are actually indicative of opioid overdose, especially when combined with the low respiratory rate. So again, it's up to you whether you would like to start the treatment at this point before moving on to E, or save it later for your SBAR. Now, exposure, you fully expose the patient and you examine them from toe to head. So you check for pedal edema, calf pain or swelling. You check their abdomen for any scars or any signs of hemorrhage, and you also palpate their abdomen as well. And then you check for signs of bruising and trauma to the thoracic region. And this would bring you to the end of your examination, and you would present your findings using SBAR. So you can say something like, I was asked to see a 41-year-old female who was drowsy and not communicating. I performed airway maneuvers to maintain the airway. I also started the patient on 15 liters of oxygen via non-rebreathing mask and administered 500 milliliters of 0.9 sodium chloride over 15 minutes. History and examination findings were consistent with an opioid overdose, which is my top differential diagnosis because of the pinpoint pupils and the low respiratory rate. So I would like to start the patient on 400 milligrams of IV naloxone. I've also requested a chest x-ray, an ABG, a full blood count, and UNEs, blood cultures, and a clotting screen, and I will chase up the results. I would also observe the patient and monitor them until a senior comes. My other differential diagnosis could be sepsis, and that is why I would like to order blood cultures, or post-op hemorrhage, given her history of a recent operation. So basically, this way, you've explained your clinical reasoning and you showed your examiner that you're a safe practitioner. You have a logical reason for everything that you've requested, and you'll keep monitoring the patient until your senior comes. And you should be fine for this station. Any questions at all, guys? So just before we move on to the next, so someone asked what IV medication was it? So for opioid overdose, we always give Naloxone. I will just type it here for everyone to see. Naloxone 400 milligrams IV. Yes, I typed it into the chat box. Any other questions? Okay, that's perfect. So before we move on to the next scenario, just remember that if the airway was not patent, try to identify the cause. Is it the tongue that's obstructing the epiglottis? Is there a visible foreign body? Or is it because of airway swelling? That could be, for example, anaphylaxis. Or is it fluids like blood or vomit. And then regardless of the cause, you call for help. And then depending on the cause, you take action. So for example, if it was fluids like blood or vomit, you'd want to put your patient into recovery position so that they don't choke on the fluids. If there was a foreign body, you might want to do some back slaps or abdominal thrusts to dislodge the foreign body. And if it was the tongue, just like in our case, you might want to do maneuvers and use airway devices to maintain the patient's airway.
Okay, so moving on to the next scenario. We have a 38-year-old male who is brought in by ambulance to the A&E following a road traffic accident. He is alert, but short of breath and is complaining of pain all over his body, especially in his legs. So you start with assessing his airways. The patient is communicating with you, but he is in a lot of pain. So we can say that the airway is patent. The one thing that you need to be very careful about is moving the cervical spine. Because this is a road traffic accident, there is a chance that the patient has injured their spine. So you must put the spine, you should put a cervical spine collar around the spine and a block so that they're not moving their head and not injuring any of this, injuring the spinal cord. So next you move on to assess breathing. So you start with palpating the trachea. You find out that the trachea is deviated to the left side. When you check chest expansion, it's reduced on the right side, it's asymmetrical. Percussion note is hyper-resonant on the right side as well. On auscultation, there's reduced air entry on the right side. The respiratory rate is high and your oxygen saturation is a bit low. So what will you do next? What do you think is going on with this patient? Yes, so there's a collapsed lung. You have tension pneumothorax. That's very good. So when your trachea deviates to one side, it's more tension pneumothorax because there's this pressure pushing it away. So you have tension pneumothorax in the right lung. And how do you treat that? Or how would you manage if you had a tension pneumothorax? Yeah, so the first step is to decompress that lung. So in an emergency, you would never do a chest x-ray. You don't want to wait for the chest x-ray and then proceed. You always want to, if you have a suspicion of tension pneumothorax, you want to treat it, and then you can do a chest x-ray to see if you've decompressed the lung. So here, the first thing you do is insert a large bore cannula into the second intercostal space. So it's called a needle thoracotomy very quickly to relieve the pressure. So air will quickly gush out of the cannula. And then once you know that you've decompressed it, the patient's saturation will improve, their respiratory rate will improve. You can then reassess their breathing, and once you've decompressed it, you can insert a chest drain, like someone said in the chat box. So the chest drain will then go into the fifth intercostal space, mid-axillary line. And then assess the patient's oxygen saturations. If they're still hypoxic, then you should consider high flow oxygen for them. Is that okay? Does anybody have any questions about it so far? Okay, so moving on to circulation. You see that the patient appears a bit pale. The capillary refill time is 4 seconds, which is a bit high. The heart rate, they're tachycardic. You don't hear any murmurs on auscultation, and their blood pressure is 100/51. Is there anything you're concerned about in circulation? Yes, so you're worried that the patient is in shock because their blood pressure is low. So the systolic is within the normal range, but the diastolic should not be less than 60. So it's 51. You're worried about them being in shock, and also the capillary refill time is low. So how would you treat this? Or any investigations that you'd like to order before you start any treatments or any procedures you'd like to do? So you wouldn't consider an X-ray at this point. However, because there's a bit of tachycardia, you can start with ordering an ECG to see if there's any arrhythmias. So in this case, the patient is in sinus tachycardia, which is fine. And you want to insert 2 large bore cannulas to get some bloods. So that will include full blood count, U's and E's, LFTs, and you always have to order coagulation and group and save if you have a patient with a likely bleed, because they've had a road traffic accident. There's a chance that they're bleeding somewhere in the body, and they might need additional blood supplements if they are anemic or if they're losing a lot of blood. So group and save is very important. And any treatments that you would consider in this case would be, first of all, start the patient on a fluid challenge. So that's 500 milliliters of normal saline over 10 to 15 minutes, and see if their blood pressure is improving. There is a chance that the patient might need blood supplements. So you can request 6 units of O negative blood and discuss with the senior if the patient would need this. So you would reassess circulation and see if their blood pressure is improving, then move on to disability. So when you assess disability, you find out that the patient is alert. The GCS is E4V5M6, which means that they open their eyes as soon as you walked into the room. They're talking to you, they're telling you they're in a lot of pain, and they're able to move their limbs as much as they can. So they're following instructions, that's fine. The pupils are equal and reactive to light and accommodation, which is normal. And the temperature is normal, the blood glucose is normal. So you can proceed to exposure now. At this point, you check the abdomen, especially to check if it's tender, if there's any guarding, because there's a chance that they might be bleeding into the abdomen. So in this case, it's soft, non-tender. Then you always have to look at the legs. So in your OSCE scenario, the legs are most probably going to be covered with a blanket. So make sure you uncover the legs at least up to the thighs and look for any abnormalities, any discolorations, any bleeding, calf swelling, pain. So in this case, there's a bit of a history about the patient. So in the left leg, they're complaining of a lot of pain, and the ambulance have already given the patient some IV morphine. Despite that, they are in severe pain. You try to examine the leg, you press on the calf, and the patient starts screaming in pain. You feel for the pulses. So the tibialis posterior and the dorsalis pedis pulses are a bit weak, though they're present. On the right leg, they don't have the same pain in the lower leg, but it's more in the groin, and they're not able to raise their leg up. So what do you suspect is going on with the left leg? You can put A, B, C, or D. I would like everybody to give it a try. Yes, so the correct answer is C. This is very characteristic of compartment syndrome. So one thing that happens in compartment syndrome is that the pain in the limb or wherever the compartment syndrome is disproportionate to the history or to anything. Even if you give them morphine, they're still in a lot of pain. You just touch their leg and they're in a lot of pain. So there's a lot of pressure building up in this leg, and you need to relieve it as soon as possible. So how would you relieve the pain? Or how would you treat compartment syndrome? Yes, and do you know how we can release the pressure that's building inside of the calf? So you perform a fasciotomy, which is basically an incision that you make, a long incision from the calf there that you would make to release all the blood buildup that might be. So in this case, there might be something going on that has led to compartment syndrome. So can you think of any causes of compartment syndrome, given the patient's history of being in a road traffic accident? Yeah, so there's trauma to the leg. There might be a fracture in the tibia or the fibula that is leading to this, and it's bleeding out into the fascia. There's no escape for the blood. So you have, it's compressing onto the vessels, which is why your pulses are a bit weak. So you have to relieve the pressure immediately. Otherwise, you might, the leg might become ischemic. So that's your left leg. The pressure is relieved. And you would have to, a senior would be doing this. You wouldn't be performing it yourself, obviously. You'll have to call for help, but that's what you would suggest as your management plan for this. So if this was the right leg, what would you suspect here, or in the left leg? What do you suspect in this picture? So the history was that there's some pain in the right groin and the patient is unable to raise their leg. Yes, that's right. So it's neck or femur fracture on the right side. And the way you would describe this leg is that it's shortened and externally rotated. So we have ordered some hip and leg x-rays, and you have it back. Do you know what's going on both of these? So I'll go through the hip x-ray, but as you can see in the left leg, there's a fracture in the tibia. And like we suspected, that might be the cause of the compartment syndrome. So you would bleep the orthopedic registrar who would come and assess this patient, and then they would continue the management from there on. So to interpret a hip x-ray, there are a few steps that I use to describe the fracture itself. So first of all, you need to identify that where the fracture is. So in this case, is it in the femur? And which side is it, the right side or the left side? So a good tool to check if there is a femur fracture is looking at the Shenton's line, which is this here. It should be smooth and continuous like this. If there's a break in that, then you suspect that there's a femur fracture. Next, you need to decide if the fracture is intracapsular or extracapsular, which means if you look at this line here, the intertrochanteric line between the greater trochanter and the lesser trochanter, if the fracture is above this there, then you call it an intracapsular neck or femur fracture. If it's below that line in this region, then it's extracapsular femur fracture. So a nice way to remember the femur is that this is your head, this is the neck, and these are your shoulders. So any fracture above the shoulders is your intracapsular, and anything below is your extracapsular. So next, you need to identify exactly where the fracture is after you've identified if it's intra or extracapsular. So a few ways to describe it is whether it's just under the head, so it's called a subcapital fracture. If it's right in the middle of the neck, so transcervical fracture. If it's on the line itself, then it's called a basocervical, which is not on this picture, but if it's right there, you'd call it a basocervical fracture. If it's anywhere under that line or within that line, it's called an intertrochanteric fracture. And then that's about 5 centimeters below the trochanters is all intertrochanteric. Under that would be a subtrochanteric fracture. And then you can also mention if there's any fractures within the two shoulders, so the greater trochanter or the lesser trochanter there. The last step is to talk about displacement of the head or of the neck. So if it's a complete fracture or even partial 50% fracture, it might move out a bit and your femur won't be attached completely to the head. So you would call it completely displaced. And for neck or femur fractures, you use what is called the Garden classification. So like you can see in this picture, it goes from Garden 1 to Garden 4. Garden 4 is complete fracture and completely displaced. So to describe this fracture, you would say that it's on the right side. It's an intercapsular fracture because it's above the intertrochanteric line. It's a subcapital fracture because it's right under the head, and a Garden 4 classification because it's fully displaced. So finally, you would reassess the A to E assessment. The patient's airway is still patent. The breathing has improved. They have good oxygen saturation on 96%, equal air entry into both lungs. You can now order a chest X-ray to see if your chest drain is in the right place. And then check the patient's circulation. So the blood pressure has improved. Check disability. So now the GCS is E4, V5, M4, and exposure, the abdomen is still soft, non-tender, and you are aware of the fractures, you've bleeped the orthopedic reg. So is there anything you're concerned about on reassessment of A to E? Yes, heart rate is a bit high, but that might be because they're in significant pain, and it might be their fight or flight response. So, and the respiration is just slightly high, but we know that we have done some interventions and it's improving. Is there anything else that's alarming that has changed since we last assessed the patient? So if you look at the GCS, it was E4, V5, yes, E4, V5, M6, and now the motor has gone down to 4 from 6. Are you concerned about that? So yes, the fracture is a pressing concern. However, in this case, if your GCS goes down from what was 15 to now 13, you would be concerned that something might be going on in their head that might have caused this. So according to the NICE guidelines, it's justified to order a CT head scan to find out what might be the cause. So if you look here, if the GCS reduces from 15 within 2 hours of the injury or since the assessment, then you can order a CT head scan. So your next steps will involve ordering a CT head scan, asking for your orthopedic review, and then you need to continue monitoring the A to E because things can rapidly change. So for example, for the GCS, it has rapidly changed, and there's a chance that they have intracerebral hemorrhage that's expanding, and that's why they're losing their motor function slowly. You want to continue basic observations at every 15 to 30 minutes and do the neuro observations as well every 15 to 30 minutes. So that's everything for the scenario. Does anybody have any questions? So in an OSCE, it's your choice. If you think you're confident with your GCS, you can perform it. It takes 2 minutes. You can say that the patient opened their eyes as I entered the room. So that's E4. The patient is talking to me. That's V5. And they're able to move all their limbs, the M6. In my OSCEs, they didn't ask us to do GCS. And even when you asked if I can assess GCS, they don't have the parameters to tell you what the GCS is. So you can just mention that ideally I would assess GCS. However, for the sake of the examination, I'm going to move forward. And you can just mention that the patient is alert or verbal or responding to pain or unconscious. I'm happy to stay here to answer any questions. In the meantime, can everybody please fill the feedback form that's in the chat box, please? So there are a few more questions I can see. So the criteria for putting, do you mean peripheral cannula for taking bloods or cannula for the pneumothorax? For the bloods, right? So when you have to put 2 large bore cannulas, is usually to take bloods. Every time you do circulation, it's standard to request full blood count and use anise because you want to find out if there's an underlying infection, any hemorrhage, any anemia and stuff. So there's no particular criteria. It's just that you need to take bloods or give fluids. So you would insert 2 large bore cannulas. For the airway, if it's not patent and you have to use tools, which one ideally is used first? So earlier, like it was mentioned in the presentation, you would start with doing your maneuvers. So you would start with head tilt, chin lift. If that doesn't work, or in our case, where the patient had a neck injury, you don't want to do a head tilt chin lift, you would do a jaw thrust. Why you don't want to do a head tilt chin lift is because it can injure the spine as you would be moving it and compress onto the spinal cord. So make sure that you only do a jaw thrust if you don't know that there might be an injury in the cervical spine. The next thing to do is to add adjuncts if the maneuvers don't work. So you can start with a nasopharyngeal airway or an oropharyngeal airway. If that doesn't work, then you move on to the next steps and start thinking about a Goodell airway or intubation, but that wouldn't be your call. That would be a senior's call, and you would ask for help at that point.
Exactly. So the first thing to do is to show your examiner that you're asking for help and that you've recognized that this is something urgent and outside of your competencies. And then once you've asked for help, just like Saloni said, you can start with the maneuvers or devices, depending on the cause.
Yes, so there's another question in the chat box about continuous monitoring for the second patient. Yes, you would, because they might be bleeding elsewhere that hasn't been picked upon while your first A2E assessment. So you want to continuously monitor to see if anything's changing until the patient is completely stable. Are there any other questions? Thank you everyone for attending today's session. If you have any other questions, we're happy to receive them by email, or I'll stop the recording and you can unmute your mic and ask it. But please don't forget to fill the feedback forms. It's really important to us because it helps us change the next presentation if people think there needs to be anything added or removed from it. And the recording will be on our YouTube page, which is BIDA Student Wing. And please follow our Instagram page for updates about the next session. Thank you.